An adjustment disorder treatment plan gets denied when the right diagnosis carries the wrong subtype code. Billing F41.9 instead of F43.22 for adjustment disorder with anxiety misaligns the record and kills the claim from the start. This guide covers the ICD-10 F43.2X subtype codes, SMART goals, evidence-based interventions, and the documentation that keeps claims clean. 5 required plan components, and the documentation cadence payers trace on every continued stay review. Adjustment disorder claims are not denied because the diagnosis is invalid. They are denied because the documentation fails 3 specific tests. A stressor not named and dated at intake is the leading cause of F43.2X denials. Billing F41.9 when the chart says adjustment disorder with anxiety creates a mismatch that compounds in audit reviews. Without measurable functional impairment at intake, payers have no basis to confirm medical necessity. Payer reviewers, Joint Commission surveyors, and CARF auditors all look for the same 5 plan components. Leave any component out, and you risk both documentation gaps and insurance denials. Step 1. Diagnosis with the correct ICD-10 subtype. Each F43.2X code maps to a predominant symptom cluster. F43.21, depressed mood, tearfulness, hopelessness, is the most frequently coded subtype in outpatient settings. F4322, for anxiety as the predominant feature. F4323, when both anxious and depressive symptoms are clinically significant. F43.24, for behavioral disturbances. F43.25 for both emotional and conduct symptoms, often at higher levels of care. Step 2. Name the stressor and date it. This single documentation element is the most common failure driving F43.2X denials. Document the specific stressor with a date, not a vague reference to life stress or bereavement. Document stressor severity within the client's cultural context when cultural factors shape the clinical presentation. Step 3. Quantified functional impairment. This is where medical necessity lives. PHQ-9 and GAD-7 at intake establish a measurable baseline and rule out a more serious primary disorder. Specific domain impairment, work, social, ADLs, with a number behind it is what payers require. Step 4. SMART goals and patient-focused objectives. Because adjustment disorder is time-limited by definition, plans must reflect that. A SMART goal names the metric. Reduce GAD-7 from baseline to 4 or below within 8 weeks. Joint Commission and CARF flag cookie-cutter objectives. Each one must reflect the individual's stressor and presentation. Step 5. Evidence-based interventions linked to objectives and discharge criteria set at intake, not at termination. Cognitive behavioral therapy, restructuring, behavioral activation, problem-solving is the most extensively studied approach for adjustment disorder. Set discharge criteria at intake, PHQ-9 below 5, and return to baseline functioning at work and home. The CPT codes for adjustment disorder are standard outpatient mental health codes. Documentation must support the code build. 90791 for the intake evaluation, 90837 for 60-minute sessions, 90834 for 45 minutes, 90832 for 30 minutes. Family therapy uses 90847. Group sessions use 90853. Session length in the note must match the code submitted. BehaveHealth.com is designed to support the adjustment disorder treatment planning workflow from intake to claim. Select adjustment disorder with anxiety, and the platform is designed to populate F43.22, reducing subtype coding errors. Goals and objectives from the treatment plan are available inside progress notes. No re-entering data per session. The platform is designed to alert staff when a review is due, so plans do not go stale before an audit. Stop losing F43.2X claims to documentation gaps. Book a 20-minute demo and see adjustment disorder treatment planning built into your EHR at BehaveHealth.com. See intake to clean claim treatment planning for adjustment disorder. Book a demo at BehaveHealth.com.